So I'd say the rationale for adding acalabrutinib to venetoclax and obinutuzumab is the hope that by adding this medication, we can increase the rate of undetectable minimal residual disease, increase the durability and depth of response. And the real benefit is that acalabrutinib has a non-overlapping toxicity profile with venetoclax and obinutuzumab, so it makes sense that they would form a nice combination together. Treatment was first started with one 28-day cycle of acalabrutinib. This was then followed by 6 monthly cycles of obinutuzumab. On cycle 4, day 1, ramp up with venetoclax began, and combination therapy was administered for a total of 15 monthly cycles, at which point the primary endpoint of the number of complete responses with undetectable minimal residual disease was assessed. Patients who are in an MRD positive CR or who are in a partial remission continue acalabrutinib and venetoclax for an additional 8 cycles, at which point the response is again reassessed. Baseline patient characteristics in the trial, the median age was 63 years old. About 62% of patients had unmutated immunoglobulin heavy chain disease, and about 27% of patients had TP53 aberrant disease, which is relatively high for a frontline trial. So the efficacy data presented were from cycle 8, and at this time point, approximately 48% of patients had undetectable minimal residual disease in the bone marrow, and 68% of patients had undetectable minimal residual disease in the blood. And we also had a complete response rate of about 25% at this time point. So we have to remember that the primary endpoint of the trial, which is the rate of complete remissions with undetectable minimal residual disease in the bone marrow, is actually read out after 15 cycles of therapy. So we still await the readout of that primary endpoint. I think the second important thing from this trial is that there is a component of treatment discontinuation, where patients who reach the primary endpoint will discontinue treatment. And I think it will be interesting to learn about the mechanism and kinetics of resistance in patients who eventually develop progression while off therapy.